log on. Want to thank everyone for joining us for Cancer Center Grand Rounds, and we really are very fortunate to have a special guest speaker today, Dr. Roy Herbst. Before I introduce Roy, as some of you may have overheard, I alluded to, just want to remind everybody that tomorrow at 5 o'clock, we have a special Smilo Town Hall with a guest speaker, Dr. Ned Sharpless, the director of the National Cancer Institute, to provide some comments and answer questions. As many of you may have seen on Friday, Dr. Sharpless offered up his priorities for the NCI for the coming year, and I think it'll be great to get clarity on what his plans are, how that aligns with our initiatives and interests, and to just in general have him answer our questions. So without further ado, let me introduce our speaker, who really requires no introduction. Dr. Roy Herbst is the Ensign Professor of Medicine, Professor of Pharmacology, the Chief of Medical Oncology, and the Associate Cancer Center Director for Translational Research at the Yale Cancer Center. Roy, as you know, is an internationally recognized leader in innovation in the treatment and research of lung cancer. His efforts really over the many years of his career have really have changed the landscape of our understanding of the biology, and frankly launching new therapies both with respect to targeted therapy and more recently with immunotherapy. And that work continues with such impact and productivity. You know, Roy's accomplishments span far beyond just his ability to innovate as a researcher and clinician, but also as a leader, having brought the SPORE to the lung program, his leadership of the lung program, which now makes it one of the most effective, most impactful thoracic oncology programs on the planet. Roy has beyond that trained countless leaders globally, and frankly, the influence of his commitment to clinical care, education, and research really is beyond measurement. So really pleased to have Roy share with us his perspectives on the work and the accomplishments he's had recently and over the years. So Roy, thank you.
Thanks, Charlie, for that wonderful introduction. And thank you, Paula, and the team here at North Haven, where I was seeing patients this morning who set me up in this wonderful conference room. We're getting back to some normalcy because the staff are all having lunch. We put a lunch out today and are watching from distant locations. So I'm really happy to be here today to give this Grand Rounds, Translational Lung Cancer Research at Yale, 10 years in review. And here are my disclosures. So lung cancer, of course, is a major problem in cancer, in medicine. You can see on the left with the pie chart, lung cancer is the biggest single piece of that pie. You can see breast and prostate right there, of course, GI cancers. But the leading cause of cancer death in most countries, 84% of lung cancer is non-small cell lung cancer, and more than half present in the advanced metastatic setting. Now, tobacco is the single largest preventable cause of lung cancer and cancer in general. And in lung cancer, we have actionable genetic mutations. So those are mostly in non-smokers, but there's been a great deal of progress, and I'm going to talk about that today. Well, I went into lung cancer when I was a fellow at the Dana-Farber in the mid-90s, and this was the status of lung cancer at that time. And you might ask, why did I go into the field? You can see here's survival curves and progression-free survival curves for patients with lung cancer. This was the top trial of the time that took platinum plus gemcitabine or paclitaxel, docetaxel. And the bottom line is all of the regimens were about the same. The one-year survival, 33%, median survival only 7.9 months. So if you had the diagnosis of metastatic lung cancer, there wasn't really that much hope. There were no predictive markers. So why did I go into the field? Well, two reasons. I happened to meet a fellow, Tom Fry, Emil Fry, actually a Yale medical graduate, who took me under his wing and said, well, translational research in this field can only be a positive thing. Give it a try. And two, it was really the only job available back then, so I took it. Now, of course, the field is very competitive to work in, and I'll show you why. So a paradigm shift was clearly needed. So here you can see the lung cancer mortality, this being from the American Cancer Society, and there really is progress being made. Men up top and women up on the bottom, and you can see 51% decline since 1990 in mortality. Now, some of that is incidence, so you can see the incidence rates are going down, but mortality is going down in excess of incidence. So clearly we're making progress. And I'm going to tell you a little bit about that during this talk. So really we've seen a new era in lung cancer. We had some better chemotherapies, no doubt they were better. Then we had bevacizumab, Avastin, anti-angiogenic therapy. That certainly helped. And then the genomic revolution, and it hit lung cancer like no other disease, a common disease, and especially in the never or light smokers, actionable mutations were seen. And then you can see all these different mutations that could be targeted with drugs. The era of personalized therapy, the work that had been done in CML and breast cancer, transferring very quickly to the large population of lung cancer. And then, of course, in the last decade, a lot of it led from here at Yale, the immunotherapy. So I'm going to tell you a little bit about our lung SPORE, and the areas where we've made progress in lung cancer really mirror what we study in our lung SPORE, whether it be smoking cessation, targeted therapy, immunotherapy, and then I have some future thoughts that I want to share with all of you. Well, we're very fortunate to have such an amazing team here. And remember, it's all about the team and the people that are working together. Everyone from the doctors to the nurses to the research scientists, the whole cancer center. So we put a SPORE in, started working on this when I arrived here in 2011. We were awarded a lung cancer SPORE in 2015. That's the New Haven Country Club where we had a little celebration. We renewed the SPORE in 2020. We couldn't, of course, go to the country club, but we had a very nice Zoom cocktail party. You can see Charlie's there with us. It was really an amazing thing. We've now refunded the SPORE, and you can see the 4 major areas we started with. Targeting PD-1, obviously, with Li-Ping, targeting EGFR resistance, smoking cessation, and we had a project with microRNA with Frank Slack, who has since left for Boston. And we have a team, and just an amazing team, and these are just the leaders of the team. There are so many others that have developmental projects and career developmental projects, but working together to combat this deadly disease. And I'm really fortunate to have been able to work with such an amazing group. So here is the SPORE as it's evolved, and I'm going to tell you about each of the projects in brief. Immunotherapy of advanced lung cancer, Li-Ping, Scott, myself, and David Rimm. Targeting the EGFR pathway in lung adenocarcinoma, Katie Paletti, Sarah Goldberg, Mark Lemon. Molecular determinants of lung cancer metastasis and drug regimens in the central nervous system, Don Wen, Veronica Chang, and Abhi Patel. And then we haven't carried this on to the new SPORE, but we're continuing the work, personalized intervention project for tobacco treatment. Probably the most important thing. I trained with Wan Ki Hong, and if we prevent cancer, we'll actually save many more lives than any of the therapies I'm going to talk to you about today. And one important thing is we developed that new project on the left from 2 developmental research projects over the last 6 years. So here again are the projects and the leaders. I just want to point out the cores. The amazing thing about a SPORE are the cores. I'm very fortunate to have a partner in Ed Kafton, who I've been working with now for 6 years. Ed has helped to bring the team together, helps to manage the team, very successful. The head and neck SPORE was just funded in large part to his efforts working with Barbara. Statistics and bioinformatics, I won't say much about it because their work is in every project I talk about today, but Steve Ma, Hangyu Zhao, you can't do anything without statistics. And I will highlight a little bit of the biospecimen core. Pathology is key. Tissue banks, pathology studies. And then the developmental research program and career enhancement program. I thank Karen Anderson, Pat LaRusso, and Harriet Kluger for this. 50 projects. Young investigators, people who weren't working in lung cancer in the developmental field, now are working on lung cancer with many new R01s and other team grants. So it really has created a whole culture of lung cancer research at Yale. I don't want to forget the clinic. I'm in the clinic. I'm in North Haven today. You can't do this without the clinic. It's got to be a seamless transition. And I won't have too much time to talk about the top program today, maybe another grand rounds. But we had a retreat back in 2012, and there you can see Anne. This is just as we brought the care centers in. The care centers are critical to this. I'm at a care center. Patients are being seen here with lung cancer. Tissue specimens are going back to Cedar Street. This is what we need. The top team, Lynn Tanui and Frank formed top 15, 20 years ago. It's tremendous. There's our clinical trials director, Roy Decker. This is our most recent retreat at the business school. And here I am at the very first retreat talking about a trial called Battle that I brought over from MD Anderson. We put 40 patients on this trial with biopsies. It helped get the SPORE going. So what about smoking cessation? Well, the health consequences of smoking are just enormous. 80 to 90 different toxins in tobacco smoke. And you know, the decrease in risk in lung cancer is seen, usually it takes about 5 years, but you never reach the baseline. And cessation after diagnosis clearly improves treatment, tolerance, and outcome. So we have a very concerted effort on smoking cessation here, and it was one of the projects of the SPORE. Certainly, we want to do a lot of work with policy. I've been involved with the AACR. We've now gotten into work with e-cigarettes. You can see on the bottom right, there's Suchitra with me and in Washington, along with Bob Durbin, at an e-cigarette briefing. We've done one with Senator Blumenthal as well. We need to stop the initiation of tobacco use. We worry about the e-cigarettes and whether patients and people will start to smoke tobacco cigarettes. Smoking rates still remain about 18%. But why is it so important? Because it's higher in our community, because we have a community that's more diverse, that has more long-term smokers. So look at the right for a second. You can see that we did a study, a personalized intervention project, and you can see 42% of our people on that study were unemployed or on disability. You can see the large number of minority patients that were on this trial. So this is so vital for our community. So Ben Toll, along with the team, and Susan Main worked with us before she came, and Brenda Cartmel, created a trial where we had patients. Our target was 276. We enrolled about 200, and we're analyzing the data now. And they either had standard cessation treatment, or they had cessation treatment with personalized messaging, gain frame messaging. What is that? For anyone who's traveled, we haven't done that too much recently, and you've seen those cigarette cartons in airports that have those really horrible looking pictures. That's negative non-gain frame messaging. But more positive messages, which we actually translated into several languages, were used to see if that would help patients to stop smoking. And then to keep them from smoking, we had a biomarker biofeedback method that Susan Main developed, looking at skin carotenoids, which actually got higher in patients who stopped smoking, and patients could see their number. So this trial is under analysis right now, but you can see the team that came together to do this. And now, of course, Lisa Fucito, who leads that effort here at Yale now, with the team doing a great job. We brought that group to Medical University of South Carolina. Here's the team there. We would go out to different forums and we'd talk about our work. You can see it was only possible because of the work of Lynn and Michal Rose at the VA and Alice Roy, the tobacco treatment groups at Yale, and all the different groups. And there I am doing the Raman spectroscopy. It wasn't too difficult a procedure. But you know, the real thing is, it got us into the community. We're continuing this work. We spoke with a Caring Ambassador program. There's Tisha Johnson in that program, and we were able to work with them to get this out there. We were able to get a grant, Beth Jones, Sakina and myself, a grant from BMS to go out and do more of this work in the community. And here we are just last week giving masks at the Fairhaven Clinic as, and the message of cessation. So smoking cessation, very important. What about targeted therapy? Well, I got into this about 1997, 1998, when I was first at MD Anderson, and I was called into the office with John Mendelsohn and Ki Han. I had, talked to them about, some targeted therapy, and I had been reading about this. They said, how would you like to lead this effort at MD Anderson? And I said, sure. And fortunately, there were trials, both in-house trials and industry trials at the time. And there was a drug called ZD1839, and we did the first phase 1 trial of that, and it worked. Now you can see I ended up working with my future collaborator and friend, Pat LaRusso. We met in 1998 working on this trial, and patients with lung cancer like this who would have had less than 6 months to live had these wonderful results. So this was the dawn of EGFR therapy in lung cancer, and of a friendship and partnership with Pat that's lasted to this day. So of course, I'm not going to go through everything in this short talk, but through those works, the EGFR mutation was discovered. Of course, Tom, our former director, was very involved in that, and Bruce Johnson and Pasiani and the group at Boston. And we actually got to a point in the mid-2000s where patients could live. Here's a patient with metastatic lung cancer who is living with cancer, taking an oral EGFR inhibitor each day, some skin issues, some mild diarrhea. But Tara Parker Pope wrote this article in 2003, Why Curing Your Cancer May Not Be the Best Idea. The idea was, lung cancer has become a disease like hypertension or diabetes. The problem with the targeted therapy for EGFR is no one's really ever cured. Resistance will ultimately develop. Well, here's a little bit about that. So we started in 1997, the second line therapies with the Gefitinib or Erlotinib, some of those agents. The mutations were discovered right around in here. The decision was made to give these drugs only to patients with mutations. So then we started to use these drugs in the frontline setting. And then we had new generation drugs. And a new generation drug was osimertinib, this drug being less toxic because it was targeted just to the EGFR mutant receptor. The other drugs targeted all EGFR receptor. So it had fewer side effects, and it also was developed to go to the brain, to the CNS. So with this drug, we had better therapy in the metastatic setting. And what I'm going to tell you about now is something that I got involved with right around this time with a team to take the drug to adjuvant therapy, take it to earlier disease. And I mentioned Tom Fry, and the one thing he always would tell me is bring your drugs to the earliest, most curable setting. Well, we did that. So in early lung cancer, let's say someone were to find themselves to have an early lesion in the lung, perhaps a few local lymph nodes, or even some mediastinal lymph nodes, the chance of them being cured with surgery is reasonable, but it's not good enough. So we would cut these, Dan Baffa, Frank Detterback and the team would cut these out, and we might even give adjuvant chemotherapy, which maybe has a 5% or so improvement in outcome. But still, in stage 1 disease, the earliest disease, only 60 to 70% of patients are cured. Stage 2 patients, only 47 to 55%, and in stage 3, only 38%. So if you have these patients and they have EGFR mutations, and it's only 10 to 15% of patients in the US, about 20 to 30 in Asia, but still enough lung cancer patients that if you could find these patients and give them something else, it could make a big difference. Well, here comes the ADAURA trial. I was very fortunate to be one of the people who designed this, along with Masahiro Tsuboi from Japan and Yilong Wu in China. Of course, EGFR mutations being much more prevalent there. We've been working on this for almost a decade. So here we took patients who had completely resected stage 1B2 or 3A disease with or without adjuvant chemotherapy, so patients could receive their standard of care. And you can see they all had reasonably good performance status. They all had brain imaging. They had the 2 most common types of EGFR mutations in exon 19 or 21, and they could have adjuvant therapy. They started within 10 weeks if they did not have adjuvant chemo, and within 26 weeks if they did. They were stratified by their stage. The trial was about an equal number of stage 1B, 2, and 3A. By their EGFR mutation status, 19 or L858R, 21, or their race, Asian versus non-Asian. About a third of the patients were non-Asian, 2/3 Asian. And then a very simple trial, and simple trials are sometimes the best. Osimertinib, 80 milligrams orally once a day versus placebo. I'm often asked, how could you do a placebo? Because there was no other standard of care. We just waited for these tumors to come back, including in sites like the brain, the liver, and the bone. 682 patients on trial. The planned duration of treatment is 3 years, so they got 3 years of treatment, and they stopped if they recurred. And the follow-up, you can see every 12 weeks for the first few years, and then every 24 weeks. The primary endpoint of this trial was disease-free survival, so surviving without recurrence in the patients with stage 2 and 3 disease. It was powered for a hazard ratio of 0.7, so for a 30% improvement. The secondary endpoint was disease-free survival in the overall population so we're continuing, and then 2, 3, 4, and 5-year landmarks, overall survival, safety, and quality of life. I was not expecting to be presenting these data this year. It was a plenary talk at ASCO. I got a call during Passover, I guess it was on Good Friday, so around April 10th or so. The trial had been unblinded. Why? Because the Independent Data Monitoring Committee unblinded the study early due to efficacy. They were doing a safety review, but they saw that the efficacy was so good, which is almost unheard of. And they did an unplanned interim analysis, and the study had completed enrollment. All patients were on for at least 1 year, so they decided to unblind the trial. So I got that call, and by the next week, we were already preparing an ASCO presentation. Why? Because these were the data. Remember, I told you that it was powered for a 30% improvement. But look here on the left. These are patients with stage 2 and 3A disease, the primary population. This is the disease-free survival for the patients on the osimertinib, the pill, versus those on the placebo. The hazard ratio here is 0.17. That means there's an 83% improvement. Again, we expected that this drug would work. But with this much magnitude, it was just incredible. And then when you add in the 1B patients, patients who would have a good prognosis to begin with, I told you half of those were cured, the hazard ratio is still 0.20, 80% improvement. So these data were quite impressive to all of us, and that's why it was presented so quickly. This is a forest plot, which is often done in these types of trials. Here you can see the unity line. Anything to the left favors the osimertinib, anything to the right favors the placebo. You can see everything is to the left, whether it be sex, age, former smokers still did well, whether they were Asian or non-Asian, the race, the stage. I told you equal numbers in all three. Even the early stage ones still make it across the line. And then EGFR mutation status didn't matter. And of course, whether they got adjuvant chemotherapy enough also, or not didn't seem to make a difference as well. So all of this was positive, a really, really very positive trial. So where are we at with this? Just to give it in perspective, I'm sure many of you want to know, what about overall survival? We won't have that for a couple of years. The trial's continuing on, and that will be followed. But right now, we want to know the local versus disease recurrence, including the sites of recurrence. I mentioned the brain, the liver, and the bone. And actually, this is a nice picture from Anne Chang and an article she wrote with Johan Masagi a number of years ago. But that's the thing. Even without the survival result, are patients recurring in these very sensitive sites? What were the subsequent therapies, and what are the quality of life? All of this is still percolating, and we'll present it shortly. In fact, I'd like to just say a word about this, the idea that we've taken targeted therapy and we've added it to our best surgery and adjuvant therapy, and now we're seeing better outcomes for patients. And I can't help but think about my late mentor, Isaiah Fidler, Josh Fidler. He died just earlier this year. He would always talk about that biology is the foundation of therapy, and that's what we've done with the ADAURA trial. Now, I wish I could tell you more. So I hinted to you about the brain mets. I'll tell you that it's good enough that there's going to be an embargoed presentation at ESMO this Saturday at 12:30 our time, and a paper coming out in a journal. I'm not supposed to talk about it, but in a journal that the Mass Medical Society publishes. So this will be out. You'll all be able to see it by Saturday. So where are we at with this now? Now we have to even add in more science. So now we have, an alliance with AstraZeneca that Pat LaRusso and I were able to develop. And you can see we're working with their tool compounds with them on all the different questions I just talked about: brain metastases, resistance mechanisms. And you can see that here's our summit meeting exactly a year ago. But now we just had a call with them yesterday morning. And now with Katie Paletti and Don Wen and Abi, rebiopsy study and analysis of cell-free DNA from ADAURA to understand mechanisms of resistance. We need to use this trial and the samples for the patients who are still on the trial to understand, when do they develop resistance in their blood? When can we measure the resistant clones? How can we determine how long to treat, when to start new therapies? So all of this is very, very exciting, and really speaks to how science has gone into the clinic and how we've evolved over 20 years to really make a difference in lung cancer with these targeted agents. And you can see here's project 2 of the SPORE. So, Katie Paletti leads this along with the rest of the team you'll see in a moment. So we actually have programs here to optimize approaches to counter on-target EGFR-dependent mechanisms of resistance. So you can see up here, we have mice. When patients recur, we get tumor and they go into the mouse. And we have mice that are resistant to these drugs, and we can try to look at new therapies and correlate that with patient data. Some of these are genetically engineered mice. And then we can look at vulnerabilities of TKI resistance in tumors without on-target EGFR resistance. There are other mechanisms, and we have clinical trials and studies to look to understand, why do patients become resistant? Because as good as we are, we're going to see this resistance emerge. So we have to stay one step ahead of this, and that's what Katie and the team are doing. So here's that wonderful project team I mentioned. Katie working with Sarah Goldberg and Mark Lemon, collaborative group. Each of the projects has its own team that meets on a regular basis. Here's the list, just amazing. The teamwork, getting samples from the clinic, PDX models, genetic models, drugs in collaboration with industry, investigator-initiated trials. That's the way we're going to continue to make progress in lung cancer. And you can see predictivity, no problem with this group. You can see a number of key publications, allele-specific patterns of resistance, approaches to overcome and prevent emergence of resistance mutations to osimertinib, which of course has only been used for a couple of years, so it's taking time to develop all this, and molecular modeling to understand these mechanisms. So a really talented group working together. And then, of course, brain metastases, we have a separate team doing that. We have Don, along with Veronica Cheng, a neurosurgeon, Don being a basic scientist, and Abhi Patel, a radiation oncologist, a translational researcher. So they're trying to look at mediators of CNS metastasis for lung cancer. We're getting CSF samples from patients who have lung metastases to understand what's going on in the CSF, in the cerebrospinal fluid. And then we're going to understand adaptive mechanisms of tumor dissemination and drug resistance in the brain, a number of key papers already published. And then we're going to use the CSF to identify biomarkers and genetic drivers of metastases. So all of this already ongoing. Again, the lab, the clinic, interspersed together. So with that, I'll now focus on immunotherapy. So if all we have already talked about was not enough, immunotherapy is perhaps even more powerful a tool if we can learn how to harness it. Well, I've been at Yale since 2011. This is a patient from 2010. So one of the reasons I was attracted to come here is I met with Scott and Mario, and they told me about this thing, MDX1106. I was at MD Anderson. We didn't know anything about it. We weren't doing any immunotherapy work back then. And Scott showed me some x-rays, and I said, wow. And you know, really Scott, Mario, Harriet Kluger, they really, you know, initiated this clinical field. Patients with refractory lung cancer. This is Maureen. This is a center point, so I'm able to show her picture. But here we have a patient with refractory disease, 3 times refractory squamous lung cancer. Very few of the molecular markers would be there. There would be very little targeted therapy for this type of patient. But look at this response. But more important than this amazing response is now 10 years later, she's still alive and well. So we actually, because of some of the work we've done subsequently, Bob Sherwin and Tisha Johnson put us in for a Team Science Award at the Association for Clinical and Translational Science. And lo and behold, we got it. You know, a little bit of money that we split. But you can see, you know, these are just a few of the many people. Ed Kaftan, of course, Harriet, Mario Snall, and then, of course, Li Ping, my good friend and collaborator, a team working on this. And I'm going to show you more recent work from this team. So I'm going to ask the question, and I don't know if Vince DeVita is watching, if this were the regular grand rounds. I'd look on the right and I'd see him there. But he's inspired me for many years. Can we cure metastatic lung cancer? A question you wouldn't have even asked 20 years ago, of course, not even 10 years ago. But I'd like to ask that question today, and then we'll talk about it at the very end of my talk. I tried to read up a little bit what's the definition of cure, to restore health, to bring about recovery from. I look up at Hippocrates, cure sometimes, treat often, and comfort always. But this is the most inspiring book. We, of course, had a grand rounds with Vince and Elizabeth a few years ago. The way that they cured childhood lymphoma and adult lymphomas. Can we do that in lung cancer? Remember, lung cancer is a little bit different disease, also affects people who are older with more comorbidities. But keep that question in mind, because I'm going to ask you again in about 20 minutes. Well, lung cancer therapy has just evolved so quickly. So this first trial up here, Keynote-1, Cole Ader was the PI of this. He's an author on the New England Journal of Medicine paper. We had this in our phase 1 clinic. You'll still bump into patients in the hall who were on this trial 6, 7, 8 years ago who are alive and well. This was Pembrolizumab. It was given to all comers in a number of different lung cancer types. But subsequently, the biomarker was shown to predict who did a bit better, PD-L1. I got involved. This is a trial I ran, Keynote-10. This resulted in Pembrolizumab getting licensed in the second-line setting. We actually showed that at 2 doses, when you use Pembrolizumab versus docetaxel, either selecting for all patients with 1% or more PD-L1 or patients with high PD-L1 at 50%, we saw a significant benefit. Then, of course, from this trial, the biomarker was used in frontline Keynote-24, Pembrolizumab versus chemotherapy. The 5-year data for this will also be presented this week at ESMO. Trust me, it looks pretty good. And then you can see the Pacific trial. This is again sort of like with ADAURA. This is stage 3 lung cancer using durvalumab, and you can see improvement in survival after chemoradiation. But I wanted to show some of our own data. So here's Scott's trial, Scott and Mario. This is where Maureen was. She was on this trial. And look, the actuarial 5-year survival from that first trial of nivolumab here at Yale, 16%. And you know what? Scott knows every one of those patients who's alive, and he's got their samples, and he's analyzing them right now. But, you know, it's really all about the tail. So if you look at this survival curve, you know, we got to do better here. We lose a lot of patients early on. But when they get to this tail, is it as good? I looked at this with Mario the other day. Is it as good as melanoma? Maybe not quite. It's still earlier, too. And this is a disease, you know, of people who smoke and have other mutations. But you know what? It's looking pretty darn good to me. And then, of course, you know, you've got to credit Harriet, you know, for her constant mentorship, you know, working with Sarah early on in her tenure here, and Veronica, again, our neurosurgeon. And they actually said, why do we have to exclude patients with brain mets from these trials? That's not the real world. Patients have brain mets. So here's a patient with lung cancer with brain mets, was treated with pembrolizumab, and those brain mets went away. This was an investigator-initiated trial. Because we were doing some of the keynote trials, we had a relationship with Merck. They helped us to get this drug in lung and melanoma. They collaborated together. And what this is showing is this is a waterfall plot. Each of these points below the line is a patient who responded. But what you can see is the response in the brain and the lung look to be about the same. So now real world trials and new trials are allowing patients with brain mets to get pembrolizumab because it apparently works across the blood-brain barrier. That's very important. So where are we at right now? Again, I only have an hour, but here's a nice slide made by Anne Cheng. She wrote a beautiful review in Nature Reviews Clinical Oncology earlier this year. And basically, we look at squamous or non-squamous lung cancer, and we look at PD-L1 expression, and we have therapies for patients who have less than 1% PD-L1, 1 to 49% PD-L1, or greater than 50% PD-L1. And that's sort of the way things are assorted right now. And approved as a single agent are 2 drugs, pembrolizumab and atezolizumab, where you can give these to patients with high PD-L1. They don't even need chemotherapy. Just for the sake of today's discussion, I'm going to talk about atezolizumab because Yale has had a very big part in its development, and I'm going to show you how we took this drug all the way from the very first in human dose now to phase 3. So about 2012, you know, Paul and I were approached by Ira Melman. Some of you might know Ira. And, you know, Ira, of course, had an affinity for Yale. He had, I believe he was the scientific director of the Cancer Center for many years. And I actually knew him because I took his course as a Rockefeller graduate student. So Ira called and they said, would Yale like to be involved in this trial? And we said, yes. We said, can we do a trial with your new drug, atezolizumab, which is a PD-L1 inhibitor, not PD-1, but PD-L1, but can we include biopsies? Because we like to do biopsies, we have that working, and we want to understand the mechanism. And they actually said, sure. So working closely with Scott and Dan Petrolak was very involved. They've had amazing data in bladder cancer, and with Paul, and then Pat when she arrived. We did this trial, and we treated almost 30 patients, maybe 35 here at Yale, and we got biopsies. So here's a patient with multiple lung metastases who had a complete response. And in this patient, we got a biopsy treatment and a biopsy when they went off treatment. And that's very helpful because you could look at CD8 cells, and these are T cells, and you can see before treatment, there's not very much CD8 T cells here, but after treatment, the T cells all swarm into the tumor. That's an example of the adaptive immune response. So we actually, in our publication and from this work, described what was happening at the level of the tumor in patients who were getting these drugs. Even more incredible is this RNA chip that we did, again, working with Ira and Dan Chen, Steve Hody and Dana Farber were involved. We had a collaborative team, as many of these clinical trials are, but you can see pre and post on this. The green is pre, the yellow is post. So you can see granzyme. Granzyme is an enzyme that's made by cells having an active immune response. So you can see the granzyme goes up in the post. This is a patient who's having a good immune response. This on here is perforin. Perforin, think about perforin as being an enzyme that makes a hole in the tumor cell and it causes it to burst. Look at the high perforin that you see after treatment versus before. So we defined in this the adaptive active immune response. This was 20% of the patients. Keep that number in mind. But most of the patients did not respond. So we also had profiles of non-responders. So here are 3 different profiles of non-responders. Again, with CD8. We had one group we called immune ignorance. These are patients where there were no T cells to begin with, and no T cells to be at the end. The tumor just laughs at what we're doing. We call this the immune desert. Then you have the non-functional immune response, where you can see a good number of cytotoxic T cells. Maybe you get a little bit of an increase. It's in the paper, I don't have time to show it to you, but that immune chip would be negative. No activation of the T cells. You don't see anything going up. And then we have the immune excluded. This is very interesting, where the T cells don't get to the tumor. And this is something we're very actively studying in the lab. How can we get these T cells to the tumor? Because if they don't interact with the tumor, and they're not going to activate. So we understood the patterns of resistance. Now let's do something about it. Well, we did a great deal of work with Atezolizumab. It got licensed in the second line setting. You'll see patients around our center who are benefiting from this. It's just amazing. So then we were offered the opportunity to lead the phase 3 trial using the drug in the frontline setting. And we said, sure. So here you can see this is the trial Empower 110. And this trial, chemotherapy naive, PD-L1 selected patients with stage 4 non-small cell lung cancer, either squamous or non-squamous. So untreated patients, 572. We used a little bit of a different assay here. Based on the work we had done with the biopsies, we thought it would be important to look at PD-L1 both in the tumor cells, more than 50%, and also PD-L1 in the immune cells, more than 10%. So we call that TC3, IC3. So we use that in this study. And we also use a slightly different antibody. I'll get to that in a moment. But a pretty simple design, Atezolizumab versus chemotherapy, maintenance Atezolizumab versus maintenance chemotherapy, endpoint being survival. Well, here's that result. These data are now in press. They'll be out not too long from now. You can see the curves cross. Definitely tells us we still could do a little bit better with our biomarker. But here's the patients who had the high PD-L1 and got the Atezolizumab. Here are the patients who got the control chemotherapy. Hazard ratio is 0.59, and these data will be followed out more. But again, an incredible result, single agent immunotherapy versus chemotherapy. We also then looked at this in this paper with other markers. So these are two, here's the SP142, which is the marker we use for this study. It's the one that's used in breast cancer. It's the antibody against PD-L1. And then here you can see the more commonly used 22C3, which is, I believe, what we run, or at least used to run at Yale. The results look the same. Slightly different populations. I won't get into this today. But this trial allowed us to sort of develop some of the biomarker comparisons, which beforehand had not been done. But even more interesting, I wanted to show this, just one slide. And again, the full report will be out soon. This was already presented at ESMO. But what you can see is we looked at tumor mutational burden, the number of mutations per megabase of DNA. And we did it in the blood using the Foundation Medicine platform. And what you can see is, here's another one of those forest plots. Here's all patients with any PD-L1 expression. But you can see that when you took patients with a blood-based tumor mutational burden, you see a progressive increase in progression-free survival as you go up in the number of mutations per megabase. Why is this important? I'll predict that someday we'll use this as a biomarker, perhaps in association with other biomarkers in this setting. Well, what about biomarkers developed at Yale and mechanisms of resistance? Again, I'm giving an overview today, but so fortunate to have such an amazing team. These are two papers with Scott as first author, but one was led through Katie's lab and one was led through Kurt's lab. Just really, seminal results. So, and I have to credit Rick Lifton. We used to meet with Rick and work with Rick. We used to go meet weekly over at his lab. So we had a great team working together. So we actually sequenced patients at resistance, and actually, lo and behold, found that those tumors that were resistant had lost beta-2 microglobulin, an essential component of MHC1. So if you know that, these patients can't get any more PD-1, PD-L1. They need other ways of activating the immune system. And then Kurt, this is a work in progress, using quantitative immune fluorescence, had a wonderful study with Scott and Cancer Discovery and the rest of the team, where they looked at different combinations of biomarkers, group A, B, and C. So what this group is, these are patients that have low TIL cells and very little, no, these are patients that have low TIL cells, and these are patients, these two groups, that have a lot of T cells. But then he looked at the characteristics of the T cells. These T cells had low granzyme and low Ki67, so they were sort of exhausted. And these T cells, you can see by the white, they had high Ki67 and high granzyme. And lo and behold, he showed that that group that had the low Ki67 and the low granzyme, they did the best. Small numbers, but we're now using our Stand Up for Cancer Alliance to validate this more. But it shows that you can identify a group of patients who are probably at more ability to respond to immune therapy. Biomarkers, predictive biomarkers. Very exciting. This work continues. I just point that out. Now, what about resistance? So we have to understand resistance better. This is work from David Rimm, Li Ping, Vamsi Valshetty, one of our fellows. He now leads the lung group at NYU. And what you can see is we actually took 450 samples from our archive here at Yale. Remember, I told you pathology is key. And we actually found that only 17% of the tumors had high PD-L1 and high TIL, tumor-infiltrating lymphocytes. The same 17, 20% I've been telling you do real well. But here's 26% of the tumors that have a lot of PD-L1, that have a lot of TIL, but no PD-L1. So it doesn't matter how much you block PD-L1 here, it's not going to matter. But perhaps there are other checkpoints in play. And then you can see type 1 and 4. These are tumors where there are no TILs. They're cold tumors. So it doesn't matter how much you play around with these immune checkpoint inhibitors. We have to inflame them first. So we call 1, 3, and 4 off-target or target missing resistance. And type 1 is the on-target resistance. Let me talk about that first. Even when you give immunotherapy to these patients, they still only respond 30, 40% of the time. So something else is going on in the microenvironment. Well, lo and behold, we have David Rimm and team, quantitative immune fluorescence, a lovely paper recently looking at co-localization in macrophages. The macrophages are going to be important, the microenvironment, and outcome looking at markers of PD-L1 in the macrophage. This is what we need to do more of. Look not just at these two markers, but at markers in other cell types in the tumor microenvironment. And we had some extra money on the SPORE. We still need more money, Charlie, but we just had a little bit of extra surplus last year. So what we did is we put it into a tissue microarray with some of the responders, non-responders, very valuable. So we can test different biomarkers now. And I thank David and his group for their complete innovation. And you can see the Rimm Lab, just a wonderful lab. The only problem is David is so good, he's now part of a head and neck SPORE. Of course, he's leading breast cancer for many years. We need many more groups like this at the Cancer Center, and I know Chen Lu is very supportive of that. This pathology group has just been key. But what about the type 1, 3, and 4 tumors? Well, about 3 years ago, we were thinking about the new SPORE and what we were going to do. And I was meeting with Li Ping, and he said, well, you have a sabbatical coming up. Why don't you come work in the lab? And I said, sure. The only problem is I still had all my other administrative work, but I got an office over there, and we worked very closely together, and I learned a lot. They even put me to work. They got me working in the lab, and I'm a PhD. I did this 20 years ago, so it was actually really good to get in the lab. But it's about the people, talking to the people at coffee and understanding the different projects. I also went back to school. I went back up to Science Hill, and I took immunology course. There's Peter Cresswell, and I learned, and through that, I learned what was going on in the lab even better. And I said, hey, here's a project we should take to the clinic. So that's project 1, the new project 1, cyclic 15. So this is a sialic acid bound lectin. It's a receptor. It's known to be on macrophages and tumor cells. This came through a large screen that Li Ping had developed in the lab to find new targets, looking at other membrane genes, homologs to PD-L1. So we're going to now work on the next PD-L1. So here's Li Ping, myself, Scott's been critical to this, and David. So there's an antibody against this now, a company, NextCure, being involved. And this trial is led by Pat LaRusso. And here you can see these are patients with lung cancer on that phase 1 trial. And there have been a couple of responses. There's a CR here. There was a PR. And there were a number of patients, here's the CR, here's a PR, and a number of patients with stable disease. So signs of early activity, that's good. Here's the responder I mentioned. So this drug already in phase 1, and we said, okay, maybe we can learn more about the mechanism in the lab and more about the mechanism in the clinic and make this a trial in our lung SPORE. So it is project 1. We have other candidates, of course, that we're developing as well. But this is a project now, and again, Pat being very closely involved. The phase 1 results, they're okay. but I think they benefit from some more science and from a biomarker. So one of the things I was able to do, having been working in the lab, is I put David Rimm together with Li Ping and the company, and it's taken a few years. This is not simple stuff. You don't just develop an immunochemistry assay. You've got to validate it. You've got to, the prevalence of that marker might not be so high. You have to enhance for it. So David now, I believe, has an assay to measure S15, Siglec-15. And actually, it's very interesting. As he's looked at it, he's found that when you look at patients that are high in PD-L1, the tumors tend to be low in S15. So it looks like there might be some sort of mutual exclusivity there, which could be very important as we decide who to treat. So this work's ongoing, and the new trial we're going to do at Yale, the plan is very soon to include biomarker selection. And then here's the trial that Scott Gettinger is running as an IIT. We reached out to NextCure, but also through our great deal of work with Merck and Pembrolizumab. They've provided us Pembrolizumab for this trial. So now we're going to take patients who have failed immunotherapy. And I'm here in clinic today, almost every patient I see, they're having issues. They need what's next after immunotherapy. So for that, we now need to get new biopsies, and we're going to have either NC318, that's Siglec-15, or NC318 plus Pembrolizumab. So we're now going to take refractory patients and either give them the single agent alone, hopefully someday with biomarker selection, or a combination with a standard immunotherapy. We're also going to treat a few patients in the frontline setting. So we're very excited about this. This should hopefully be open very soon. So again, science from Yale, moving to the clinic with science going back to the lab. And of course, again, I can't emphasize enough today, it's all about the team. So, Katie Kerr came to visit, so it was easy to form a nidus of people who wanted to be in the picture. There's Li Ping, there's Pat, Paul Eder, Charlie. I got myself a good spot. You can see we have a team. It's all these people. They're the ones who are doing the work. They're seeing the patients. There's Joe Kim. It's just amazing the team we have. We probably have, I know we have the best phase 1 unit in the world. So I've gone through a couple of little vignettes. You can see I'm excited, I'm enthusiastic. I think we've made a difference. I've seen it myself. There's nothing like seeing a patient who's alive 10 years later that you've treated with your own clinic. But what is the future? Well, it's very hard to predict the future, but can we cure metastatic lung cancer with immunotherapy? And I've been asking this question to a lot of people, and I'm going to say yes, but in some cases, or at least patients can remain alive with controlled disease. We've seen it. I was talking to Scott earlier today in the clinic. We have 10-year survivors from the very first trial, maybe 10, 20 of them. We have people who are alive, maybe not 10 years, but 10 years, up to 10 years, but 7, 6 years. We used to celebrate survival at MD Anderson in stage 3 disease at 5 years. So it might be time to start getting these patients together. We have to learn, though, a little bit more. My point now to all of you is we can treat these patients. It was well tolerated, but we need to know in advance who are these patients so that those who can get immunotherapy alone can get it, and those that need combinations of drugs or chemotherapy, they can get it. So that's where I think we need to put all of our efforts in the next few years. So do we need to personalize immunotherapy? Absolutely. We spent 20 years personalizing targeted therapy. I showed you that. And we're still not there yet. We're still waiting for more data. It's still a small population that we're treating. We need biomarkers. We need better combos. We need more science. We need innovative trial designs, collaboration, and public-private partnerships. I would say to all of you watching right now, the future is now. I'm going to give you an opportunity to work with us in the last slide. So what are we waiting for? It's time to target immunotherapy. And we can't just give these drugs to all patients. It's amazing the number of diseases that have benefited. All diseases benefit to some extent, but there are cold tumors, there are tumors that don't have much PD-L1. We have to better understand this, and that's going to mean better science in the clinic. Now, Scott shared this with me this morning, and this is our exceptional responder cohort. So you can see these are patients for whom we have tissue, and you can see months from starting immunotherapy. So we've got quite a few there that are out 3-4 years. So now what we need to do is we need complete analysis of these patient samples to inform future studies to personalize immunotherapy. That's ongoing. My prediction is it's not going to be just sequencing. If we do sequence, we're going to have to sequence both the tumor and the host. So maybe this Generations project will help us that's being done at Yale New Haven. But this is something we can do, we will do, we must do. Adaptive trial designs and new protocols are needed. I didn't have much time to talk about this today, but a lot of this tissue sampling has come from the BATTLE trial. It's 15 years since we started that trial at MD Anderson. I think the same principles would apply. Adaptive trial design. England has a national lung matrix project. I think this is something that we certainly want to think about, targeted therapy for patients based on biomarkers. But we already have it in the US. This is the Lung Map trial on which I'm the PI, a large public-private partnership, about 100 of us in the leadership working together. We had this open at Yale. We're one of the #1 accruers. Herder Chow does a great job with this, and there's Machal at the VA, but targeting patients with mutations, but also patients who are immune resistant. There are many new drugs. We need to work with these drugs. We need to combine these drugs. Again, this slide just meant to show that if we combine them, we have to do it rationally, and we have to do it based on the science and what we've learned about the immune microenvironment. This is an amazing trial that Scott leads with Richard Favell, David Hafler, Kurt, Katie. We have Ipilimumab, Nivolumab, now an approved regimen. We have about 30, 40 patients on this trial. It's open at 9 or 10 other sites. Everyone gets tissue, blood, and stool for the microbiome. And we're putting the markers together. It's just at the point now, it's been 3, 4 years, that we're going to try to get some information on who benefits and who doesn't. So finally, I told you I'd give you a challenge. I would propose that we need to do the BULLDOG Trial. I've been talking to Pat, and the best phase 1 and drug developer I know, and she'll get the drugs. She understands the science. Ed Kaftan, we need him. Ed's just the most amazing person at bringing teams together, and we've worked so well together. So we're going to actually take a trial now. We're going to try to use biomarker development, biomarker prediction to treat patients based on that with trials. And the reason I want to show this now is we're now accepting applications. So I'm announcing a new PO1 group that's forming today. We're going to start having some meetings. I'd like to take the best science of Yale, the best clinical science. I'd like to merge them together. I can tell you it's not going to be easy. In fact, most people tell you it can't be done. I used to work a lot with Judah Folkman. He used to tell me that's exactly the time when you should do it. So we are going to make this happen, and I'm very excited, and I think I've shown you that progress can be made. So I just want to thank all of you today. It's just been an amazing team effort. I want to especially thank the Yale School of Medicine, Bob Alpern for his support, the T-Tier grants that have led to these SPOREs, and now Nancy Brown and her team who have continued to support this, Brian Smith, and of course, Charlie and the Yale Cancer Center. For all the money we get from the NCI, we get all the resources of the Cancer Center, we get additional money for the DRP and CEP programs, the career development, and that's really important. So with that, I'll thank you, and hopefully we have time for a couple of questions. Thank you very much.
Roy, thank you. That was just fabulous. And congratulations to you and really everyone on the team for just an amazingly impactful work in this field.
And I got some of the team here, so I had a little bit of a live audience. So, okay.
Excellent. Excellent. So folks should submit their questions on the chat function, but I'll start while people are typing. So, I have a couple of questions. One, that I'm just curious because I've seen the data from the ADAURA study before, but I didn't fully appreciate when you look at mutation type on the forest plot, there seemed to be potentially a difference depending on the mutation type where it almost looked like the confidence limits were not overlapping. Did I misinterpret that?
No, well, the good news is that both mutation types benefited in this trial. In the metastatic setting, there's much more of a benefit for the exon 19 deletion versus the exon 21 point mutation. As you can imagine, you would think the deletion might be less likely to become resistant. But yeah, I think the numbers there are about equivalent. One of them does a little bit better, but I think the good news there was that both were at least quite well significant compared to the one. The trial, of course, was empowered to compare the two.
And then, sort of on a related note, curious to see what your expectations are for IO in the future of IO in the adjuvant setting, and then to what extent targeted agents and IO can be combined either in the adjuvant or the metastatic setting?
Those are great questions. So, IO, of course, the trials are all ongoing. So, they're being done in many cases without biomarker. So I worry a little bit about that because, these agents do have toxicity. I didn't mention it. I assume most of us are familiar with this, but, the itises that you can get with these immune therapies, while mostly low level, certainly pneumonitis is something to worry about and carditis and other things. In the adjuvant setting, I think that I would give it a 50-50, whether these trials will be positive. It's hard to follow. We don't know the PD-L1 status often of these tumors. We're not following micrometastatic disease. I think in the future, Charlie, we're going to use MRD techniques and these bespoke models to know who has minimal residual disease. I'd much rather see a trial where we know that someone has minimal residual disease and use the trial, the immune therapy to enhance that. So it's being done sort of, just as the next step. And it might be that these are tumors that are not driven by PD-L1. Maybe they're the type 1, 3 or 5 or 4. So I do worry about that a little bit. But like anything else, depending on the population they get, if it's a highly smoking-related population that might have higher tumor mutational burden, perhaps it will be positive. But it gets to all the same questions: how long to treat? What are you treating? But I'm glad that the experiments are ongoing, and hopefully there are blood samples that are being obtained from those trials so that we can look and see what's happening in real time. Now, the other question you answer is what I'd love to do. We know that targeted therapy, you have an EGFR mutation, 80% chance the tumor will respond. The patient feels better within days. So why not use immunotherapy, targeted therapy early on, knowing that resistance will ultimately develop, and then bring on the immune therapy, which takes a while to work, but will have a much more durable response. That's been tried, and at least in lung cancer, the toxicity has just been unbearable, both in Asia and in the US. Not sure why, but I guess the reactivation of the immunity in patients that are getting these EGFR agents that do tend to have issues with the skin and the lung in terms of interstitial lung disease, those toxicities have precluded that so far. That said, there are other ways other agents that can be looked at that are now being tried. LAG3, TIM3, maybe the Siglec, that all should be looked at. So I think that has to be the next step because, EGFR mutated disease, as good as it is, at least in the metastatic setting, we still have, many patients, in fact, most will recur. So I think trials are warranted there. And then, I'm hoping that in the ADAURA, the longer duration of therapy with a better agent in an earlier setting will result in cures, but we don't know that yet either. We're going to have to follow those patients, for a while for survival.
Thank you, Roy. Actually, a few questions coming in. One comment that I'll offer quickly is Stephanie Aline writes, "Congrats, beautiful," multiple exclamation points. Stephanie, thank you
Stephanie.
for the comment. Pat LaRusso asks, do you think the scenario will be the same with G12C RAS mutations in combination with IO?
Okay, so so I didn't mention that, but KRAS has been the holy grail. So G12C mutations in lung cancer account for about 12 to 13%. That's more than EGFR mutations. Now, there will be a big talk on G12C and KRAS, the Amgen drug at ESMO, I believe this Sunday or Monday. We know that there are responses. That's been presented already. In fact, Yossi and I wrote an editorial on this last year. We also know that the activity was best in preclinical models in immune competent animal models. So I do think that those agents are just begging to be combined with immune therapy. The one thing we don't know yet, and hopefully we'll see this weekend, is what is the durability of response for KRAS agents alone? You worry since KRAS is so upstream that there are going to be so many bypass pathways there. Will it have a median duration of response of at least 6 months or more? If not, it's probably going to have to be combined. So my thought is that very nice that we have these agents. The G12C, not as good in colon cancer, of course, but that's a smoking-related KRAS abnormality. Now, we do have data that KRAS mutant patients do respond to immunotherapy, but I think that combination is something that hopefully we're already doing here at Yale. So Sarah Goldberg already is running trials. Rick Wilson, Pat, and Naveed Hafez has a trial in the phase 1 group. These are all things we're studying here.
Great. And then a final question from David Rimm. Is a diagnostic test needed to see who will benefit in the adjuvant setting, or should every mutation patient get, I guess, osimertinib, OSI, he writes. So I imagine osimertinib.
At this point, no. I think everyone who's EGFR mutant, again, there are going to be some who say we don't have survival data. I can't share, if I were giving this talk a week from now, I think I could put the nail in the case because, certainly if one were not to metastasize to the brain, I think that's a good thing. But I think that, yes, we're going to learn from this. I can't wait till Don Wen gets those samples and he can sequence them and tell us who's going to metastasize to the brain, so we know that in advance. We can look at the cell-free DNA and know that someone's developing early resistance, and maybe we get Katie some tumor and she can develop an animal model. There's still room to do better. But I think right now, assuming approval, I think we'll use this. And one of our surgeons right here, I have to convert him, that he should send a sample for EGFR mutation, and hopefully we'll do that. And hopefully David will help me with that.
Well, Roy, thank you. I know we're out of time. It was a fantastic talk. Great work. Thank you for all that you're doing in your leadership. And again, thank you for a fantastic presentation.
Thanks for all your support. Again, it's the Cancer Center that supports the teams that really can make the difference, that can help the patients.
Well, thank you. Everyone have a good day, and we'll see you next week.